Thank you so much for joining us. There are so many people on here today. This is awesome. We're truly excited. As you all know, we are celebrating our 20th year at Phia. There's our logo. And today is a different webinar than typical. I'm a little more nervous today. I feel I'm already off my game. And there's one reason. My wife is literally sitting to the left of me. And she's staring at me right now. It is driving me nuts because I'm not used to this. I'm used to either being by myself in the basement or pre-COVID with all of our other people. All of you know who they are, Ron, Brady, etc. All of us together having an amazing time. But today, she's sitting right there, and I'm dying for her to get out of here so I can become myself again. So, folks, if you've noticed a different me over the next hour, or if you notice that all of a sudden, wait a second, Adam's back to normal, I guarantee you it's because she's walked out of this room. So, anyway, in addition to that, today I am in our new beautiful offices in Canton, Massachusetts. It is awesome. Matt, go to the next slide, buddy. It is awesome. But we're going to be talking about the old issues under a new environment. It's not the same old song, folks. All these things that have happened over the past few months. Our members' behaviors have changed. The patients' behaviors have changed. The way physicians bill have changed. Hospital billing practices has changed. Telemedicine, the theories of it, what's behind it, all that has changed. We're going to talk about all these great issues. Next slide, please. As you all know, we're always trying to stay ahead of the curve. It's no different with COVID-19. So far to date, since this horrible pandemic started, we have worked on 1,154 different projects related to COVID-19. Any questions you have, please email us at pgcreferral@phiagroup.com. Next slide. Let's talk about the overview. What are we going to talk about? We're going to have Jen McCormick talk about PGC and the FAQs. A lot of letters there. We're going to talk about updated PCORI Fee. That sounds exciting, huh? Not really. Next, Brady Bizzaro is back as always. He'll talk about the political update. Then we'll talk about COVID-19's effect on healthcare consumer behavior trends, testing, pharmacies, telehealth, direct primary care, surprise billing. I think a lot of you probably heard about that patient who had coronavirus who received a $1.1 million balance bill. Yeah, well, he's alive. Next, mental and behavioral health management. We're going to talk about that as well because what we're seeing now is people have been sitting at home. They're getting a check from the government. They're not working. And what are they doing? They're drinking and doing drugs. Amazing. Speaking of drinking and doing drugs, next slide. These are my co-speakers. First, we have the wonderful, amazing. Where's the next slide, Matt? A little slow today. Today's speakers, you got myself, that good-looking guy way on the left. In addition, we have Ron E. Peck. Say hello, Ron.
Hello, Ron.
We also have Brady C. Bizzaro, who I guarantee you is not wearing his Phia fleece. It is way too hot outside. Say hello, Brady.
Hello, Brady.
And the lovely, amazing, the only reason we have hundreds and thousands of people dialed in today, Jennifer M. McCormick. Say hello, Jennifer.
Hello.
One day, folks, one day when this pandemic's over, Jen will say hello, Jen. It's going to happen. Ron, what do you think? You think it'll happen one day? You think if it was my last wish before I died, that Jen would say hello?
You know what? Only if I grant the patent to her. I'm still pursuing a claim against Brady for infringement.
So I want to know, Brady, are you in the office today? Are you here at our beautiful new spanking headquarters or not?
I am not. No, not today.
So I'm the only one here. Well, that's good. That's fine. All right, folks. Thank you so much. Next slide, Matt. Make sure, folks, don't forget to follow us on LinkedIn. There are thousands of you who are on it, but there are thousands of you who aren't. Go on there, search for the Phia Group, and start following us. Next, be sure to download our podcast. Folks, we have a beautiful, brand new spanking podcast room. It is awesome. Ron, I can't wait for you to see it. Pat, the producer, will
I can't wait to hear it.
It's going to be awesome. We have a beautiful room. Thank you so much for listening. We have some amazing podcasts out there. Next slide. We want to give a special shout out to Jill Schmidt. Jill is the Director of Account Management at Assured Benefits Administrators. And what did Jill tell us? She said her fun fact is she's obsessed with Christmas decorations. I decorated 5 full trees, including one made up of 30 pieces of Department 51 Snow Village houses shops. What? What does that even mean? What is that? I have close to 40 25, 30 gallon plastic tubs to store all the decorations inside my house, not to mention the hundreds of Christmas ornaments. Listen, Jill, I would love for you to come to my house and decorate. If we possibly have you do that, I will pay for your flight. I'll pay for the mask to wear on the plane. I will pay for your transportation. Come to my house And I don't need 5 full trees. I just need 1. But that'd be great. Ron, what do you think? Should we have her do that? Maybe at Phia too?
Well, you know, for a second there, Adam, I thought that was your screen name, Jill Schmidt, that was your stage name, and you were just trying to get away with a confession.
I really want to have an interview with Jill. You think, guys, Matt, reach out to Jill, see if she'd be willing to do a podcast with us, maybe around Thanksgiving, because I'd love to talk to her about her obsession with Christmas decorations. I mean, her family must think she's crazy. But Jill,
Adam, if you want to grease those skids, Adam, be sure to send her those pictures of you as Santa at that Boys and Girls Club event you do every year.
That is true. That's a good one. But Jill, you will be getting the Phia backpack, sweatshirt, T-shirts, all the Phia goodies will be coming your way. If you want to dress up Santa in one of our Phia fleeces, that'd be great. But thank you so much for listening. Next slide. Our new office. That's me. Yes, I am on top of the building with our beautiful sign, 40 Pequot Way. It is wonderful here. And with that, folks, I'm going to turn it over to Jen McCormick to talk about PGC's most frequently asked questions. Go ahead, Jen.
All right. Thank you. Thanks, Matt. Okay. So, we couldn't go without talking about some of the updates that relate to COVID. And with that, our frequently asked questions for this past month have really surrounded these new rules about the extensions that have been brought to plans. What do they mean? How do I deal with them? So the first question is about how the new COVID timeline extensions actually are going to work. So as everyone hopefully knows how excellent I am at math, I can explain this in a way that hopefully makes sense for everyone, in a way that you can actually apply for your plans when it comes to the administration of the benefits and claims and COBRA. So under these regulations, there is a specific outbreak period. And that outbreak period is defined as March 30th until 60 days after the end of the COVID emergency, whatever that might be. So that is the period that we are talking about, the outbreak period. Keep that in mind. So all of the days that occur during that outbreak period do not count, must be disregarded for the purposes of determining certain dates. So that means that any deadline that would begin after March 1st of 2020 won't actually start until the end of the outbreak period. So any deadline before or after March 1st, 2020 is not starting until after whenever this outbreak period ends. That's an important note here, because when it comes to what relief is being granted, there's numerous examples. A couple of them are the 30 days that you normally get to request special enrollment under ERISA. Another would be the 60-day COBRA election, the period that you would make COBRA premium payments, which we'll talk about next, date the claimants may file an appeal for an adverse benefits determination, dates that you can request for an external review. So those are some pretty significant dates for plans when it comes to how things should be handled. And we always know that timing is everything when it comes to claims and COBRA, especially since there's lots of different entities that are involved when it comes to the administration of benefits. So what's the good news here other than this relief for the participants? Well, the good news is that the departments are not going to they're not going to penalize the plans if they are administering the benefits in accordance with these rules, which would essentially be contrary to the terms of the plan document, since we're offering this outbreak period and this little bit of relief. But of course, at Phia, it's always our recommendation to make sure that the plan has adopted language to account for this outbreak period, so you can avoid any sort of coverage gaps that could potentially arise by having a relief period that is not otherwise being documented. So at this point, what you need to do is make sure that you're reading the regulations, making sure for all the different examples that are listed within the relief that you are calculating correctly based on the outbreak period. All right, Matt, next slide. Okay, so this is one that's a little bit trickier, and should you have other questions about this, please feel free to reach out to us, because I think this is a really important concept, and this isn't going to be the first time that this is going to arise. So the question, under the COVID-19 timeframe extensions, is a plan required to continue to pay for claims under COBRA for those that have not paid their premiums or they're paying them late? Or can you terminate them for non-payment and then reinstate later on? So you might already realize there are some special rules and a grace period that apply under the existing COBRA regulations. But with this extension for those COBRA elections and the premiums, how is this going to play into it? So the good news is this is actually addressed within one of the examples in the joint rule. Specifically, I think it was example number 3. And in that example, it notes that the plan cannot deny coverage based on not receiving premiums prior to the ultimate determination of the true date after that outbreak period where that extension runs. So you cannot deny coverage based on not getting those premiums prior to that extension or the outbreak period. So based on this example, it's implying for us that it is permissible that the plan makes benefit payments retroactively. So while you can't terminate coverage, you're not required to actually issue benefit payments for claims that incurred during the period for which COBRA hasn't been paid. So no termination of coverage, but you don't necessarily have to issue benefit payments. What's important here to take away is that the plan is accurately and effectively communicating this with providers and patients regarding these benefits, so there are no questions and no confusion. Also, if you're further confused, you can refer back to the existing COBRA regulations, and they outline some of the plan obligations for how the claims should be handled as well. And that should be an important note for people to consider. And like I said, if there's questions about this too, you can feel free to reach out to us. Next slide, Matt. All right, the next topic that we're going to get into here is the PCORI fee. How exciting, right? So this is in response to IRS Notice 2020-44. So as a reminder, we all probably thought we were done with PCORI, right? We thought this was going away. Well, as a reminder, the PCORI fee is what we're actually using to fund the Patient-Centered Outcomes Research Trust Fund. And this is being calculated annually based on the average number of lives that are covered under a plan. This fee is actually mandated by ACA, and it's helping to fund research about the effectiveness of certain treatments. And generally, for a calendar year plan, this fee must be paid by July 31st, following the last day of the plan year. So for many plans, that's coming up, right? So we thought that this fee was actually going to be terminated. Allegedly, it was supposed to sunset back in September 2019, but in December of 2019, this was actually extended for 10 more years. Thanks. So for plans ending on or after 10/1/19, but before 10/1/2020, they probably didn't anticipate having to actually calculate the number of lives during that time period. So there are certain methods that they could use. There's the 3 traditional methods, the actual count method, the snapshot method, or the 5500 method. Those are still available for plans to use, but there is some sort of transitional relief here too that is helping these plan administrators use any reasonable method for calculating the average number of lives. So if the plan sponsor uses a reasonable method to calculate the average number of lives for the plan year that ends on or after 10/1/19, but before 10/1/2020, then that reasonable method just has to be applied consistently for the rest of the year, and that's totally fine. The dollar amount here that we're using for this plan year is $2.54, which is up about 10 cents from last year. So if the plan thought or the employer thought that they were all set with PCORI, bad news is that they're not. Good news is that they can use this transitional relief and use a reasonable method for doing the calculation. All right, Brady, I'll turn it over to you to talk about the political update.
Great. Thanks, Jen. And look, just like we're not done with the PCORI fee, unfortunately, we're not done with COVID-19 either. So we got to spend a little bit of time talking about the latest developments on the pandemic front, because unfortunately, what we are seeing.
Garrett, are you done with your Phia fleece? That's what we want to know.
I'm not wearing my Phia fleece. No, it is way too hot for that. So
has it been
you can cross that off.
Have you buried it? Is it thrown away, or you still have it?
I'm waiting for a new one. Is what's going on really with that, but
Okay.
I still have it.
All right, so Matt, let's make sure we give him a new one, okay? All right, you can keep going.
I appreciate that. So, like I was saying, the last week or so, you've been hearing the news that obviously we've got a ton of people that are out and about protesting or visiting bars and beaches and restaurants. We'll see the impact of that probably next week, but already in more than a dozen states across the U.S., you're seeing an increase in confirmed cases. On the next slide, you'll see, if we can get there, exactly what I mean and where the hotspots currently are. It's really in the Sun Belt. So about 22 states now reporting the highest numbers yet they've seen of new cases. And when we say new cases, it's important to understand there is actually a problem here because it's more than just more testing. it's actual hospitalizations. It's actually the number of positive tests that come back as a percentage. Typically, you want that number.
That's my question here, Brady, right? So I see that increased testing may account for some. So, what I have seen, and I want you to, if you have this information, it'd be great, is we obviously know that there are more cases of it, because if you have more testing, obviously you have more cases. But are we seeing higher hospitalization? Is there proof of that? Do we have that? And where is that actually happening? Is that Arizona, Texas, Florida? When you say spikes, you mean hospitalization spikes?
Yeah, so the hospitalization spikes are happening, especially right now in Arizona, Texas, and Florida. Arizona in particular has got a real concerning problem where they have, I think, 1,600 new cases a day, and that's not a good sign for them. But that's the key number to look at, is the number of people that are hospitalized, because that means that they're actually sick enough to actually have to go into the hospital. And the other number, like I said, on testing, is you want to look at not just the number of people who are being tested, but how many of those tested are coming back positive. The number the CDC says you want to get to as a state is below 5% positive rate. In Massachusetts, we've got something like 4.7, 4.8, which is a good sign. But the problem is about 20 states are seeing their numbers, their positive returns go up. So we'll have to watch and see. The states I listed out here are particularly problematic. So if you're in one of those states, definitely be aware, watch what's going on. The impact on the healthcare system there is definitely going to be more intense than other places. But it leads to a political decision for a lot of leaders, right? Because we're now in the midst of summer here, and they're going to have to decide whether the risk is worth the reward. We don't want to see things close down again, but the healthcare system is particularly strained in these states where there's lots of hospitalizations. And we'll have to see, like I said, how the impact of these nationwide protests is going to have, what impact will that have? I know in Massachusetts, they've set up special testing sites encouraging people to go get tested for free who were protesting. So hopefully that happens nationwide so they can control some of the outbreaks there. But one thing we've seen that is apparently way out of control is the cost of COVID-19. Adam mentioned this news story that's really blown up lately from out of Seattle here, where this guy was the longest recorded hospitalized case of COVID-19 in the U.S., whopping 62 days. He obviously survived, and when he was discharged, he got this bill that he was quoted in the story as saying almost gave him, almost caused his heart to fail a second time, because it was 181 pages long and $1.1 million, over 3,000 different charges. They charged him like $9,000 a day for his ICU room, and of course he was there for 60-something days. It was very, very expensive for his treatment, but importantly, he's not going to pay really any of this bill partly because of the CARES Act, actually. So if you remember, the CARES Act has a requirement that any provider receiving a portion of the relief funds that were allocated for providers, for hospitals, are not allowed to balance bill patients. So if you, as a coronavirus patient, are receiving care at a facility that has received federal funding, then you're not going to be balance billed. But that means that his insurance, in this case Medicare Advantage, is going to be paying that bill almost entirely.
Hey, Brady, in this situation, the $1.1 million bill, that's the Medicare rate? So am I making the assumption that if it was a private insurer, it'd be a much higher bill?
It would be a much higher bill, yeah. That's the implication here from this article. Yeah. So it would be a higher bill for a private plan. And again, the takeaway here is that as patients, your plan participants are still vulnerable, because if they go to a hospital facility, right, to have treatment and they have COVID and it's not one that took federal funding, then they can balance bill. And so that's the concern here, is that this guy is, he's getting away scot-free in some way, obviously, notwithstanding the fact that he had COVID-19, but his insurance is paying the bill. I bet you will see future cases. You've already seen a couple that are much less, but I think you'll see higher bills in the future of people who get treatment at hospitals that didn't take the federal money under the CARES Act and that are allowed to then balance bill. And that's going to cause all kinds of problems up and down the healthcare system and with the employer. So we'll be watching to see if any more cases. I know Ron had a thought on this too, because it's such an eye-popping number, 1.1 million.
Yeah, and it's interesting. Adam actually just brought it up as well. We are talking about what would they be charging a private payer? What would a private payer be paying? What would they be charging Medicare? What is Medicare actually going to pay once they apply their fee schedule? It's probably going to be pennies on the dollar. Ultimately, what I think is maybe disappointing about the coverage that this story has gotten, and it's something that maybe we're looking past, is the fact that this gentleman, and he's a good guy for saying it. He says he feels guilty for having cost the system so much. It reflects this sense of inevitability that these bills are, for lack of a better term, legitimate, and that they're going to be paid. And ultimately, the question just comes down to who's going to pay it. And the fact that people don't necessarily understand how the system works, or the fact that this bill is, in essence, fictional, as long as you're covered by Medicare or even a private payer who, while they would end up paying a lot more than Medicare will, even then, that this is really an issue when it comes to out-of-network claims, balance billing, when people get these what we call charge master balance bills. And I think that maybe this is a good opportunity to use this as a tool to teach people in general how the billing works at these facilities.
Yeah, absolutely. All right, next slide, Matt. We got a few more updates here on the political side. This is one that every time we make these slides, I try to make sure I have the latest information, but just yesterday there was a very important Supreme Court case that does play into this slide here about Section 1557. I know we've already gotten a lot of questions about what does this mean for plans in terms of covering transgender services. So let me give you my initial take on it. And the truth is, this opinion came out yesterday. It's still being digested by a lot of legal scholars, including ourselves. But I do have some thoughts. And essentially, what happened here is last Friday, the Trump administration reversed a rule, an Obama-era rule, that under the earlier rule, Section 1557 of the ACA protected transgender individuals by preventing health plans from discriminating against them based on healthcare services. It expanded the definition of sex, basically. That's what the earlier Obama-era rule did. On Friday, the Trump administration officially rolled back that rule. They issued a new final rule that would have restricted the scope of Section 1557 and returned the government's interpretation of sex discrimination according to the plain meaning of the word sex. Now, what happened yesterday was the Supreme Court issued a surprising opinion, a 6-3 ruling written by a conservative justice that basically did the opposite again. He interpreted the word sex to include orientation, and it's interpreted in a way that now I think is going to make it much more difficult for the administration to enforce this rule, because it says in the context yesterday that employers can be sued for discrimination based on how they treat transgender individuals in employment. If you fire someone for being transgender, for example. So the implications of that decision from yesterday by the Supreme Court are going to make this rule a lot harder to enforce. And so what I would say is, people are asking, well, what should we do? I would have said before the Supreme Court case, if you wanted to go ahead with the Trump administration's rule and limit services based on gender identity, you could do that, but you would likely still face a civil rights lawsuit. What I would say now is you're definitely going to face a civil rights lawsuit if you try and limit benefits there, because the plaintiff is going to use the wording in yesterday's Supreme Court case to try and apply it to healthcare, right? And that's going to be the only thing left for the administration to say, is that, well, employment's different than healthcare. You shouldn't be interpreting the word sex to include orientation and gender dysphoria in the context of healthcare. But it really makes it more difficult, and that's why it's such a big case from yesterday, and it's very surprising. So the takeaway is, as of now, this final rule has gone into effect on Friday. So if you do want to limit the scope of services you're providing to people based on their gender identity, is a very big risk based on this decision. So that's the best initial read I have on this. We'll have more to say about it because, like I said, it was just released yesterday. But it's a big deal, this case, and the impact it's going to have for transgender individuals and those that are undergoing services based on gender identity. So next slide, Matt. A few last things I want to just mention here in our update is that people may have been asking what's going on with the next stimulus package. The HEROES Act was passed. All these things were planned that would have helped even with healthcare services and obviously direct money for people who are unemployed. Unfortunately, the Senate's not taking that act up. But the administration has said that they do want to see more money sent to Americans, and they want to reform the unemployment system that's been put in place temporarily. We expect that something will happen in July, early July. There's a long August recess. Congress isn't working much this summer, if you haven't noticed, only a few days a week, it seems. So if they do take up any bill, it likely will come in early July. And we've heard some rumblings that there might be some liability protections for employers when people return to work and contract COVID-19, for example. There's some rumbling about action on surprise billing. We'll get to that in a bit later. There could even be another paycheck protection program. So we'll have to see how that shapes up. But it is notable that the administration has said that they do want to see another actual package get passed, and probably will be, in the $1 trillion range again. So that's a big deal. Last two quick things here is the IRS is proposing to allow HRAs to pay for direct primary care. Here we go again. That's a big deal if it happens. I think I mentioned a few webinars ago that in the CARES Act, in an early version of the CARES Act, this was made allowed. You could actually use HRA funds for direct primary care. Somebody removed it. I haven't figured out who that was yet. But now the IRS is bringing this proposal back. Comments are due in August. That would be a big deal because it would expand the use of direct primary care tremendously, which we know in our industry is a big deal. So we'll be watching that. And then finally, a couple more states, Illinois and Wyoming in particular, have created what's called the rebuttable presumption for workers' comp claims. This is something that SIA is following very closely. They published a chart that follows each state by state what they're doing in terms of expanding workers' comp eligibility. What this basically means is for workers in certain categories, first responders, healthcare providers, et cetera, that if they contract COVID-19 in the workplace, there's a rebuttable presumption that they contracted it from the workplace. You as an employer have to rebut that presumption. So it's really a pro-employee thing, and we'll be watching that as more states add on to that. But for now, I want to turn it over to Ron because we had a special visitor here in Massachusetts last Friday. Ron?
That's right, Brady. And we're not talking about your in-laws. No, I'm just kidding. Hey, look, that's Governor Baker back there. He can try to hide behind that mask, but we know America's most beloved governor when we see him. But that's not really what's important right now. We were blessed by the president of the Secretary of Health and Human Services, Alex Azar. He came and he visited one of the facilities for which we are famous in Boston, that being Beth Israel and the Leahy Health System. And basically, they're going on a campaign from coast to coast, reminding people that hospitals are open for business. And it's interesting because this is happening now, but Adam and the rest of the team, and really anybody who's in the health benefits industry, you're in the business of receiving claims, paying claims, dealing with providers, negotiating out-of-network bills, things like that. You are in the business of dealing with medical service providers. And you, like the rest of us, have probably noticed a change in the type of claims and the volume of claims. And we noticed very early on, the moment we realized people were not going to be visiting hospitals quite as often, that the elective procedures were going to drop off substantially, that even people who are suffering from emergency situations may be avoiding hospitals and other providers' offices. We anticipated that would have an impact on our business and the services we provide. But if you're a hospital, that's not a down the line impact. That's an immediate impact. And if we go to the next slide, we can actually see some of the statistics that are being brought up when we talk about that reduction in care. Colonoscopies, a lot of these sort of examination, joint replacement, elective procedures that you can more or less postpone, right? Down 90%. Now think about that. If you're in the business of providing healthcare, that's where your revenue comes from, and it's down 90%. Maybe it's not a big surprise that you're going to charge people over $1 million for COVID care, right? Cardiac surgery, which again you would think is urgent, still down 70%. Stroke, you can't really control that. And here's what I think is interesting: both cardiac and stroke and heart attack, unlike colonoscopies, joint replacements that you can postpone, they're elective. These other items are tethered to emergency situations you can't control. And yet, the care is down 58%, 33%. That, to me, tells me that people are suffering these emergencies and they're just fighting through it rather than going and visiting the hospital. Ron, using the ER. Yes, sir.
What we have seen, and this says Boston, but folks on the call, you're not obviously in the Boston area, right? What we have seen nationwide overall, just based on the claims data that we get, so we obviously get data extracts on a daily basis from our clients. We have seen so far a 37% decrease in the number of claims overall since the beginning of the pandemic. So those are flu shot claims, could be COVID claims, et cetera. But overall, just a 37% downward trend. It's starting to reverse. We're starting to see some uptick. But what we're seeing based on hospital surveys, et cetera, so far is that not even the hospitals expect to be back at pre-COVID numbers until the fourth quarter of this year, meaning we would expect the rest of 2020 to have downward numbers compared to 2019, with potentially in the first quarter of 2021 back to normal, as long as we don't see a quote unquote second wave with more shutdowns. But that's here or there. Ron?
Yeah, that's a great lead in. Matt, next slide. Since that's a great point, I do want to start to drift away from Massachusetts and look at nationally. It's not a coincidence. They've surveyed these people in general, consumers of healthcare, and those surveyed, 72% have dramatically changed the way they use traditional healthcare, which means a couple things, right? One, actually seeking out care, but then two, the tools that you use to obtain healthcare. And we'll talk a little bit later about things like telehealth. What I think is really important, and maybe something that we need to keep an eye on, is that this is going to be a real test, right? A trial by fire for a philosophy in healthcare that's more or less been accepted as a truth for as long as I can remember, which is that preventative care, right? A dose of prevention, right? Is important in that it prevents complications or escalation of issues down the line. When you have 41% of respondents saying that they've delayed healthcare services, right? People with chronic diseases, things that are starting to worsen over time. My question is, fourth quarter this year, next year, like Adam said, when things start to get up and running, will the people who have delayed or avoided care now, will their conditions, not only is it just delaying the treatment, but increasing the severity of the need down the line? That'll be very interesting to see.
Ron, think of this, right? Look at our own company, right? So right now, we know based on the capacity here, we know that we can have a certain number of people based on Massachusetts law as relates to COVID-19. Right now, about 40% of our employees who could come to work, like they're not taking care of a kid, like the way you are, they don't have daycare issues, etc. They just don't feel comfortable being in public.
That's
Those
right.
same people are that 42% who are uncomfortable going to a hospital for any treatment. So I'm less concerned about the delayed people. So like they're delaying a knee replacement surgery, right? So they're hobbling for another couple months, but they're not going to need an extra knee replacement surgery. But those 42%, those are potential people who are not going to catch a disease or a sickness or a treatment now. And a year from now, it's going to be 10 times worse. So that's where we can see what's going to happen. That's where we can see potentially really large hospitalization claims, a big, increase in the number of claims and the size of those claims as well.
Yeah, Adam, that's a great point. And before I turn it over, just as a personal example, most people on the line right now have probably heard from past podcasts or blog posts that I've posted. It was just under 2 years ago that my wife was diagnosed with non-Hodgkin's lymphoma, and thank goodness that she's through it and it turned out all right. But I look back to 2 years ago when she was first diagnosed, and she was noticing symptoms, and eventually she went to the ER. They took the X-ray and determined what it was. Imagine if instead of 2 years ago that were today, and she wanted to delay, right, or avoid going and getting these symptoms checked out because of the fear of this pandemic. And everybody who's listening probably knows, the longer you put off treatment of things like cancer, the worse the outcomes. So I will be just like you, Adam. I'm very interested to see what the long-term effect is going to be, not just in general, but as these benefit plans start to see these complications and advanced issues that maybe could have been nipped in the bud, maybe. Next slide. And Jen, speaking of of testing, this is I'm looking to you for to administer the exam.
Yeah, that's what I'm here for. Yeah, this is something that has been coming up recently. We talked a little bit earlier today about the increased case count, and that's in part due to the increased testing that's becoming available. And according to this survey, we found that most of the respondents, about 2/3, actually wanted to be tested for COVID-19, but more than 36 are actually concerned about their ability to access testing and treatment. So we know over time that this has really transformed in the ability to actually get this test available to us. And only speaking from Massachusetts and what we see here, at first they were turning people away unless you had all of these certain criteria met, you were unable to get the test. But now we have set up these drive-by centers for people who are the frontline workers that you're able to get testing. Now you can even walk down the street to your Walgreens or CVS or Rite Aid and get a test. So testing is becoming more and more available and accessible. And it seems like based on the results of this survey and actually all kinds of surveys that we're seeing out there, that people do actually want to get tested. But where? Where do they want to get tested? So it seems like the majority of people, or about 70%, actually would feel the most comfortable getting tested at their doctor's office, while only 18% would feel comfortable getting tested at their workplace. So while this is pretty interesting, you should note that there are lots of different articles that we're seeing about universities, particularly those large universities and some large employers actually, that are announcing their plans for the COVID-19 testing as part of their supporting their return to work or return to school. That in order for those individuals to actually return, that they are going to be mandating or requiring some of this testing for COVID-19 to be done. Even more so, some of these articles are saying that these universities or employers are going to require a repeated test every 14 days, which is going to require millions and millions of tests every single day if that's the case. So everyone sort of has a different opinion about the value of the repeated testing or the testing and whether this actually is going to help with the contact tracing or identifying some of those hidden carriers. But we know that there are, although there's different opinions about this too, asymptomatic spread that can maybe put a damper on the results of this or create some of these false alarms. It is something to be aware of, that testing is going to become a more important part of our everyday until we get this vaccine. Last thing before I switch to the next slide is there was an article yesterday about the Red Cross, and they are having, I'm sure many of us know, a difficult time getting blood donations because they've had to cancel a lot of these blood drives that they normally frequently have. And now, in order to maybe help boost or incentivize or encourage to get some of these blood draws, they are saying that as part of the blood drive, they will actually do the antibody test to help these donors learn whether they have been exposed. So they are hoping that this is actually going to give an increased interest in blood donations. So moral of the story is, if you are interested in getting an antibody test, a free antibody test, maybe you can give some blood. All right, next let's talk about pharmacies. So this has also been something that has been pretty interesting when it comes to the impact that it's had at the pharmacy level. And I'm sure that pharmacists are pretty unique in the sense that their popularity hasn't really changed in the number of people who have actually come in to visit. And pharmacists are actually pretty unique in that you can go to a pharmacist in person without an appointment. They're one of the few providers that throughout this pandemic, you can just go and see without having to worry about needing a particular time to go.
Jen, this is Adam.
Yeah.
Compare this slide to the one about the hospitalization or the doctor's office. So they're afraid to go and see the doctor and sit in the doctor's office, but they'll go to CVS and sit there waiting for their drugs to be filled, prescription to be filled.
That's
It's
right.
weird, right?
It is weird. You know, and I think a lot of this too, a lot of the in-person use where people were so not fearful about going to the pharmacy is that even in my neighborhood, maybe it's like this in other neighborhoods, while the actual store, the Rite Aid or the Walgreens was closed, you could go in the back entrance just to the pharmacy. And maybe people felt a little bit safer that they were going to see someone or who was giving them medicine. At first, for me, my first thought was, oh, geez, I need to stock up on cold and flu supplies and make sure I have all the infant Motrin and Tylenol possible. You know, the other thing that these pharmacies were faced with at the outset is that there were some supply chain issues, and people who knew that maybe they had some sort of chronic condition or they knew that they had asthma. I mean, my son has asthma, and my first thought was to go to my pharmacy and get as much albuterol as I could to make sure that I could look out for him should be some issue arise for him. And I don't think that I was the only one that thought that way. I mean, you can tell here that 49% of people felt very comfortable getting their prescriptions at the pharmacy and talking to their pharmacist. 47% actually received new medications. And other things that people are actually using here, and something that we use for our own Phia plan, was modifying our allowances to people get a 90-day supply, or even doing an override for their refills, knowing that this is essential for some of the patients and employees that have these chronic conditions. So, you know, there's talks too about how this is going to, the result of COVID is going to have a larger interim impact on what the pharmacist's role is going to be as part of the healthcare system. And maybe as a result of this, there'll be some changing or loosening of the regulations to allow the pharmacist to get more involved in patient care services. It's evidence like this that proves that people feel pretty comfortable going to the pharmacist and talking to them about their problems. So maybe this is going to be a key to the future of what we can see at the pharmacy level for different types of services that might be available.
So Jen, we're not seeing a big change in pharmacy usage, right? People are still going to the physical stores. But I know the next slide's going to talk about it, but there's a big difference when it comes to telehealth. So mail order pharmacy hasn't really jumped as much as we might think, but that's not the same for telehealth, right?
Right, yeah. Telehealth is definitely something that has been an important part of the whole COVID impact for everyone. And whether it is to see the doctor, and this is one of the things that was required as part of the CARES Act for the telehealth visits to actually be covered if that was part at 100%, if that was part of the trigger to diagnose or to require COVID tests. And Brady, I'll turn it over to you to talk more about telehealth.
Thanks, Jen. Yeah, I mean, continuing the theme here of transformations in healthcare because of COVID-19, telehealth is probably one of the biggest ones. I was reading an article before about saying that telehealth has been accelerated by 10 years because of COVID-19, and it's really here to stay. And that's important because the pandemic, may only last a certain amount of time, but I think the fact that some of the data collected in terms of patient experience and satisfaction with telehealth, I think is a good sign that you'll see this kind of technology stick around. The use of telehealth has surged by triple during the pandemic. That's a huge deal. These numbers here from polls conducted of nationwide polls, 58% view their doctor as the most trusted source of information, but only 31% feel comfortable actually going to the office. 28% have used telehealth in the last 3 months. Almost 90% were satisfied, and 46% of consumers are comfortable with telehealth now. That's a big deal. It's also a big deal that CMS announced a few weeks back, or maybe even a month or so ago now, that the reimbursement of telehealth services will now be on par with in-person visits for the duration of this pandemic, however long that lasts. And they also relaxed the rules, remember, for virtual consults, so you could do it across state lines. So if you're a physician in Massachusetts and you want to conduct a telehealth screening for a patient living, in Rhode Island or New York, you could do that. That's a big deal. It obviously drastically increased access and use of telehealth. But most people like telehealth. They're happy with it. It's being used for all kinds of things, for like Jen mentioned, diagnosing from a distance. There's even some new technology that gets a bit beyond telehealth. And I want to talk about that for a second here on the next slide. You'll see that the digital transformation in healthcare is really a big deal here. One study done by McKinsey, a large consulting firm, predicted that $250 billion in healthcare spending could shift to virtual care because of this pandemic. That's in the coming years. There's a House bill introduced that would permanently boost Medicare reimbursement rates for telemedicine pay. That's probably not going to get a vote this session, but we'll watch and see where that goes. That'd be a big deal. It shows that there's confidence in telehealth at the congressional level, and that if the reimbursement's there, it makes it a worthwhile pursuit. But what else might we see aside from telehealth, or perhaps beyond telehealth, because of COVID-19, and what would that mean for employers offering health plans? Well, I think you'll see a lot more vendors out there popping up that are working on virtual care capacity, is sort of the term that's out there now. One of these examples is any technology that would allow for a contactless experience. So as an example, one healthcare executive was talking about how you would go almost like an airport check-in kind of experience at a hospital for an appointment. When you'd be for an in-person visit or a virtual visit, you do everything online. You wouldn't have to touch anything. You would register at a kiosk in a hospital lobby. Maybe they'd have some kind of facial recognition software, but you wouldn't have to touch anything or really even speak to anyone until perhaps the very end. So any kind of technology that would allow for that is where we see the trends going. Obviously, healthcare apps for things like contact tracing and self-triaging are huge, and they're likely to stick around because contact tracing can be used not just in epidemics, but for monitoring and sending SMS messages to maybe at-risk populations in your employee pool. So if you have a lot of unhealthy or people with chronic conditions on your plan and you want to send them reminders to take their medication, for example, or to make sure they're not missing appointments, there already are a lot of vendors out there who offer services like this, but these kind of data mining tools are just going to really explode, according to a lot of these consulting firms.
Brady, my question relates to this. So Jen, I want to bring you in on the discussion real fast too. This contactless experiences, these telehealth, telemedicine, et cetera. What percentage of our plan documents that we work on do we think has enough in there, enough meat on the bones as it relates to telemedicine?
A small percentage, to be honest. Unless there is a particular vendor that is offering the service, which is very common for us to see that there's a vendor that offers the particular telehealth services. But as a line item on its own, generically, that's not a line item that you commonly, if at all, see in a plan, which is a problem since we're starting to see these claims for telehealth because people have no other way to go to the doctor or they're scared to, but yet the plan document doesn't necessarily support it.
Yeah, it's a case of the technology.
I'm assuming, Brady, this is going to tie into our next slide, right? When it comes to direct primary care, right? There's a huge boost on that, I would think, too, based on this.
And I'll turn it over to Ron for that. But just one last note. Remember before I mentioned how there would be the ability to use an HRA to pay for DPC according to the IRS proposed rule. So I think this one is one you're also seeing action on. And for that, I'll turn it over to Ron.
Nice. All right, I'll take it. Listen, so Adam, great point, and it really does tie into DPC. A lot of plans that felt that they were ahead of the game as far as plan language and telehealth were concerned felt that way because they were paying a specific telehealth vendor, like Jen mentioned before. They're paying someone to provide telehealth, right? A single vendor. What I don't think they were prepared for, and what we're seeing today, are that providers that are traditionally not telehealth providers are becoming telehealth providers. But because those providers are in network, you're still required to pay the bill, even though it's a telehealth bill. So I don't think that the language addresses it adequately. So the example being, let's say I go to visit a primary care physician, right, my PCP. He's part of, let's say, the Partners Health System here in Boston. Normally, I go to visit him in person, and the claims come in under my network agreement with Partners Health. Now, I'm doing a telehealth visit with my PCP. The claim is coming in. My plan is inadequate. The claim is still under the same network, but you don't know how to treat it because it's not an in-person visit like it used to be. And that, I think, is another value add for DPC, because not only is the direct primary care physician already being paid a capitated fee for their services, but the telehealth that they provide is contained within that same fee as well. So if you are using a DPC model, you don't have to worry about how to treat the telehealth versus the in-person.
Ron, I read an article recently. DPC doctors are one of the few physicians who have not seen a decrease in the amount of revenue they're making because they're getting paid on a per employee per month basis, right?
Doesn't surprise me. Doesn't surprise me.
Even in houses, they still make their money. In addition, when people do visit their doctor at a direct primary care, there's no one in the waiting room. There is no waiting room. You walk in, you have a meeting. Right away, you have a visit. In addition, you mentioned virtual examinations. It's like, like on your iPhone. Well, I can actually just have a video conference call with my doctor. So all that ties in telemedicine, telehealth, in addition to an actual practical office visit as well. So you get the benefits of both.
I think, Adam, right now in Massachusetts, they're opening restaurants for outdoor seating. You need to call and get an appointment. And there's no waiting. They take you right to the table. DPC was doing that beforehand. I think that it's unfortunate that it took a pandemic to show why these tools make sense. But, like you, I anticipate, and I'm not surprised at all, to see that there isn't a decrease in the use of DPC as a result of this. So we can move on to the next slide there, Brady. That's great. Great graphics, Brady. I want everyone to know you're responsible for the illustrations.
It took me a long time to find a smiley face of looking surprised. I want to let you know that. But look, just quickly on surprise billing, because we want to get to mental health here. I mentioned before about the CARES Act did a little bit of something to protect patients, but it still is a key focus on the administration for healthcare reform. I feel like we've been talking about this for years now. Surprise billing, drug pricing, nothing ever happens. Well, right now, main focus is geared toward air ambulance services because the NAIC has gotten just frankly annoyed and fed up with it. They've written letters to Congress asking for action, at least in this area of surprise billing. But the White House has floated an idea of surprise billing legislation in the next package in July or August. They do need a win in healthcare. This could be a pretty easy area. You do have bipartisan agreement. We'll have to wait and see. But I want to save time for the next few slides for Jen and Ron on a really big, important issue.
Brady,
Sure,
before you move on, one thing to mention, because of what's happening, based on the stats that we gave you over the past hour, one of the key areas is this is the time, if any, where you should be trying to negotiate deals with billing departments at facilities. This is the best opportunity.
Right.
They want to get paid. They need cash in the door, not just bills. They need cash. There's a cash flow issue out there as well. So if there's any time, you got 10 balanced bills sitting out there that haven't been resolved, don't wait. Proactively pick up the phone or contact Phia. We can do it for you and get these claims resolved, because no time is better than now.
Right. It's one silver lining in this whole mess. On the next slide, you'll see mental health, and we can turn it over to Jen to talk about this very important issue.
Thanks. All right. So yeah, shifting gears a tiny bit here, it's talking about this growing, but also really important consideration, mental health. So while mental health considerations aren't really new, the rising costs and potential uptick in uses and utilization has actually required us to pay attention. Pandemics are stressful. So COVID has really contributed to the increase in issues that we're seeing here. And based on a April of 2020 poll from Kaiser, it noted that over half of U.S. adults, or 56%, actually report worry, stress, anxiety, specifically related to COVID, that is causing them negative effects on their mental health and well-being, whether it is not sleeping as much, not eating enough, or overeating, or maybe increased alcohol use. And there are so many people that are reporting that there are lots of these different issues, and it's contributing to employers and employer health plans in significant ways. You know, a couple of examples here is that this is causing individuals to potentially lose work or be absent or not able to be present, maybe need to take a leave of absence. Maybe due to this increased stress, they're needing new medications, or there's additional claim costs that are being incurred. Maybe as a result of these increased conditions or mental health issues they're facing, they might need some sort of disability assistance or going out on disability. Maybe there's a work comp-related issue that is being involved in here too. So the moral of the story is it doesn't, yeah.
If we can, I know we want to go to the next slide, but one thing I want to bring up is, as the CEO of this company, I can tell you honestly, I've never put as much emphasis on the mental behavior health claims or what we do about it as other claims. I just haven't, I'll be honest, right? And then after seeing the next slide, if you don't mind going to that next slide, after seeing this next slide, it's proven that I'm wrong. There's no question, if you're like me, where you just sort of put mental health like, there's nothing I can do about it. Or, here's the bottom line. Look at these stats. There are some major problems that are going on now, an increase in behavioral health issues, mental health issues. There's no question that this pandemic has affected us negatively. I mean, look at the numbers. Alcohol sales up 243% from the same period a year ago online. And look at alcohol purchases up, liquor purchases up. Antidepressants, 78% of all antidepressant prescriptions filled during the week ending March 15th were for new prescriptions. That's crazy talk. These people don't just get off these drugs, they stay on them. Sorry, Jen, I know it's your slide, but I just have to jump in.
No, this is significant stuff, and it's a wake-up call to pay attention. This isn't going to go away. And a lot of these studies are saying that these, not only these really, really high numbers, but these aren't fading. These aren't going away. These are continuing to increase. These numbers are going to continue to rise. Something needs to be done. Some of the things that you can consider here are, maybe you want to have a way to reduce costs. Maybe you want to manage care. Maybe you want to put some sort of pharmacy controls in place. There are certain things that employers can do. And to talk more about that, I'll turn it over to you, Ron.
Thanks, Jen. So next slide, you can see here, again, we were talking about COVID-19 and the pandemic and how it's sort of a wake-up call for mental health and behavioral health. But that doesn't mean that when it's over, that it's going to go away. So just like direct primary care, just like claim review and large claim negotiation, I think we use this as an opportunity to look at it as a wake-up call to address the issue, but don't assume that it's going to go away when the pandemic goes away. This is something that's going to stick around. And the thing you need to focus on is that idea of management. You're looking for some program or something that's going to act as a gateway or air traffic controller for mental and behavioral health needs. rather than just emphasis on medication, right? So if we go to the next slide, the things that you would be looking for when it comes to this type of health management, mental and behavioral health management, you want to make sure that there's a program that is focused on actual hands-on assessment, right? So, and I think the slide might be frozen there, Matt, when you get a chance. But there you go, thank you. So the hands-on assessment, that is, rather than just take 5 minutes, listen to what they're saying, and then prescribe a drug, instead try to assess, is medication the right approach, or is there something else that we could do? There may actually be some instances where there is a less severe, potentially even permanent solution, whereas other cases may require things like ongoing care or prescription medication. But ultimately, the point is, it's not a one-size-fits-all solution, and you need to make sure that whatever approach you take or program you use is providing that case-by-case assessment instead of painting with a broad brush, which would be costly medication.
Ron, I want to make sure I let you know this and let our listeners know. So we obviously, again, I mentioned, we started taking this seriously. I started taking this seriously this year when I saw what was going on. And we have looked at all different types of vendors, all different types of EAP programs. And the organization that we work with now, we'd recommend to anyone. So we have this on Phia's plan. Please reach out to us for details, information as to our partner, how we work together and what we're doing, because it's definitely a much more proactive approach than what, I mean, to be honest, we weren't doing anything in the past. And now what we're doing, I feel very confident going forward that would have been to help, that we'll be able to protect our employees and help them in this crisis.
All right, so Jen, take it. You can take it back.
All right, thanks. Yeah, so just to quickly summarize here, a couple of things that we can consider or that we have seen plans actually implement to try to mitigate some of this cost are to maybe create a narrow network that is having direct contracting available for those certain mental health services or treatments that might be available, or maybe doing some sort of aggressive care management under the health plan where you're working to authorize particular treatment plans based on the level of care that's being provided. Another consideration is taking a look at those claims. It wouldn't be a shock or a surprise to any of us if maybe there was egregious or excessive billing that was occurring as a result of these mental health claims. So taking a look at those claims, auditing them, reviewing them, making sure that there's nothing that is out of whack. And last but not least, the employees are the most valuable asset that an employer has. And those are the ones that are actually going to be incurring these costs. So not only is it important for the plan, but it's important for the employer to take care of their employees and make sure that they are functioning at the highest possible level so that we can do all that we can to be as productive as possible during these super challenging times for all of us. I'll turn back over to you, Adam.
Well, folks, thank you so much. Our hour has ended. We obviously appreciate the thousands of you that have dialed in today. On behalf of Ron, Jen, Brady, Matt, and myself, thank you so much for joining us here today on the Phia Group's webinar. Join us on July 16th, 1 o'clock Eastern Time for the next one. What's it going to be about? I have no idea. Oh, I forgot to tell you, my wife is still sitting here. I can't believe it. She actually sat through a whole hour of this thing. I don't know if she actually listened, but she's here. Anyways, see you next month. Have a great beginning to your summer. Thank you.